Hi everyone, this is Doug Nelson with Precision Neuromuscular Therapy, and I'd like to go over some of the anatomy concepts that would be helpful for you when you're taking the low back seminar. So first, familiarize yourself a little bit with the SI joint. In terms of, as you see on the screen, there is a posterior SI joint, which is the meeting of the innominate and also in the sacrum. So any muscles that cross that joint are going to affect the movement potential of the SI joint and also the pressure receptors inside, but there's also an anterior SI joint. So in the seminar, we'll be dealing with both, but just familiarize yourself with the anatomy, and again, understand that muscles like the piriformis, like the multifidi, have a profound effect on the joint itself. Secondly, there is a whole lot of new information about the importance of the lumbodorsal fascia, that in terms of proprioceptively, in terms of nociception, just the nerve receptors inside the lumbodorsal fascia are much greater than we ever knew before, and that in terms of providing stabilization in the back, in terms of providing an anchor point for the latissimus, and also in terms of pain, now injecting hypertonic saline into the lumbodorsal fascia has more of a spread, has more of an effect than even deeper into the muscles themselves. So we'll go over some of the new research with this, and then and that will guide our approach to treating the lumbodorsal fascia or the thoracolumbar fascia. We'll also spend some time talking about the anatomy of the disc, which is the nucleus pulposus and the annulus fibers. If you'll notice, each of the annulus fibers is running at a 45 to 55 degree in an opposite direction. So that's important for stability of the disc, and also we'll go over some of the anatomy stuff with the disc that I think you'll find really helpful when you start to look at discal issues and nerve irritation. Next, in terms of the Erector Spinae, very important muscle in terms of both stabilization and also movement. We're going to focus on mainly two sections. One is the longissimus section, which is the one that is right next to the spine. I think this drawing by Barbara Cummings is a little bit deceiving in terms of the longissimus section being a little closer to the spine. The iliocus is right on the kind of rib angle. Very important muscle, triplanar muscle involved in lots of different kinds of movements, and also a source of a lot of back pain and thoracic pain that people tend to have. So review the anatomy of the Erector Spinae if you can, please. Also below that, we're going to focus on the multifidi, an extremely important muscle in terms of its role and function in the low back. And we're only going to deal with it in the lumbar spine. In the thoracic spine, it kind of changes position and a little bit changes function and becomes much less important. At this area, at the PSIS, the multifidi in that area is about an inch thick. It is really thick, really strong, and plays an enormously important role in lower back discomfort. And if you're not familiar with the iliolumbar ligament, that is the ligament that stabilizes L5 on the innominate. And in the 50s, actually, a guy named Hackett did this thing where, in the past, we've injected muscles with isotonic saline with an irritant and seeing that they have referral patterns. Even in the 50s, this person, Hackett, injected into ligaments, and they too have referral patterns. So in low back pain, this is an important ligament, and mostly its function is to stabilize any anterior motion of L5 on the sacrum. The serratus posterior inferior muscle is a muscle in the lower ribs, attaches to the inferior side here, and becomes bilaterally a stabilizer and unilaterally deals with rotation. Of course, I think most of you are familiar with the psoas and the iliacus, so we'll just review that anatomy. One thing to know about these muscles is that the psoas in general moves the femur on the spine, whereas the iliacus moves the pelvis on the femur. So kind of the direction, the function of them is quite different. In many ways, because it's different, there's no muscle in a way called the iliopsoas. It really is, there's an iliacus, there's a psoas. They have different functions in terms of their movement potential. And of course, the QL. And in the QL, one thing I want to point out is that this muscle has 3 different fiber directions. It has the iliovertebral, that's this one, coming from the ilium, going to the transverse process. It has a costovertebral, that's coming from the ribs to the transverse process, and an iliocostal, that's the one that's coming straight up. Most of the time, I think you'll find the problems will be in the iliovertebral and the costovertebral sections. So we're not just going to treat the QL, we're going to try to isolate each one of those 3 sections of the QL. So if you could review that anatomy, that would be helpful as well. So hope this is helpful. I hope you enjoy the seminar. I think you're going to learn lots. Thank you so much.